Good evening. Good afternoon. I'm the host of the webinar tonight. Okay, and I am grateful then that everybody in this meeting room and coming from Africa and Middle East. And tonight we have several speakers. Excuse me. We have Dr. Xiaosong Qin, who is the director of laboratory medicine from northern China, a prestigious university which is called China Medical University. And we have Professor Dr. Ahmed Kepler, and he is from University in Egypt. So he's the director and head of pathology. So, and then we have Dr. Raymond Simon Lopez, who is a medical expert from Mindray as well. So he has many years of medical and also industry experience. So, and then last we have Mr. Osama Said, who is a staff product specialist from Mindray as well. He's working in Egypt branch. So, and then in the last, we have Q&A sessions, which we have discussion available in this session. Everybody can raise questions, and then we are going to have our speaker to answer your questions. And then I hope everybody enjoy the discussion for this session. And according to our agenda, so the first speaker is Dr. Xiaosong Qin, in Chinese Qin, Dr. Qin. So she earned her PhD from university in Japan, and right now she has many publications and also leading Department of Laboratory Medicine in northern China, a university in northern China, which is called China Medical University. She also has many experience in different laboratories and also as a visitor in several organizations, including Harvard Medical School, and also in one university hospital in Italy. So now let's welcome Dr. Qin to present her speech, her talk. Her talk tonight is about HBV laboratory diagnosis and the abnormal result interpretation. Since Dr. Qin has a conflict arrangement tonight, so we are going to play her recorder as presenting. So we are not going to see her in person. So this little bit kind of pity tonight. So, but anyway, she will share her record, and we are going to play her talk right now. Okay.
Distinguished colleagues, good evening. I'm glad to have the opportunity to meet you online. I'm Qin Xiaosong from China. Today, I will share the topic of the laboratory diagnosis of hepatitis B virus and abnormal results interpretation. According to the WHO report, about 2 billion people worldwide have been infected with HBV. About 350 million people are chronically infected with HBV. Approximately 1 million deaths are caused by HBV infection every year of liver failure, cirrhosis, and liver cancer. Both Asia and Africa have relatively high prevalence rates. HBV was originally called serum hepatitis or long incubation hepatitis and has an incubation period of 60 to 90 days. The transmission primarily through blood. The major sources of infection including iatrogenic transmission, such as injection with a contaminated needle. Blood transfusion sometimes is also a way of transmission. The virus may be contracted by inoculation of infected blood, saliva, or semen through a small break in the skin or a mucous membrane. So close contact or living together with HBV-infected patients is also one of the ways of transmission. Hepatitis B-infected mothers are more likely to infect newborns through vertical transmission. Studies have shown that the intact HBV molecule has a double shell structure that contains several different antigens or antigenic material. There is an outer envelope that incorporates the hepatitis B surface antigen. There is an inner core that contains an HBV core antigen. Also, within the core is a structure consisting of double-stranded viral DNA, as well as a material called HBV-E antigen, and an enzyme known as DNA polymerase. Currently, there are 3 separate HBV antigen antibody systems: surface antigen, core antigen, and E antigen. The symptoms are nonspecific in the early stages of the disease, such as fever, fatigue, nausea, and loss of appetite. Generally, the patient will experience pre-icteric, icteric, and convalescence phase. 95% of adults recover, and a small percentage progress to fibrosis, cirrhosis, and carcinoma. The HBV markers include nucleic acid and serological markers. At the early stage of infection, the HBV nucleic acid is the first marker appeared. Then after a month, the surface antigen, E antigen, and anticore antibody, IgM antibody appeared one after another. The core antibody IgM is the first antibody appearing, which can reappear at recurrence. Subsequently, with the appearance of antibodies such as surface antibody and E antibody and the core IgG antibody, the seroconversion was indicated. For a clinical suspected HBV infection, usually we will perform immune HBV tests. It can be ELISA qualitative or CLIA quantitative tests. If there is a positive surface antigen, means there might be a HBV infection. Next, usually we will perform HBV DNA test. If the test is reactive, means the HBV infected virus replication and high infectious. If the DNA test is non-reactive, means HBV infected virus not replication, and low infectious. The appearance of surface antibody means HBV recovery or vaccinated. If all the 5 HBV assays are negative, means non-vaccinated, and the population is susceptible populations. For acute HBV infection, the serological markers changed is like this. The surface antigen is the earliest serological indicator of HBV infection. Usually appears in 4 to 6 weeks. Usually disappears 12 to 20 weeks after onset of symptoms or laboratory abnormalities in 90 of cases. It is the most reliable serological marker of HBV infection. At the early stage of the acute HBV infection, the surface antigen, the E antigen, and anticore antibody positive means the patient is highly infectious. With the enhancement of immune response, the level of surface antibody decreased. E antigen turned negative, and E antibody appeared. With the surface antigen turning negative, the surface antibody appeared. For chronic HBV infection with E antigen seroconversion, the serological markers change like this. First, the surface antigen will persistent for longer than 6 months. This is a carrier state. If the E antigen is persistently positive at the same time, an active carrier is indicated. The presence of the E antibody indicates reduced infectivity, may also be found in chronic infection. Chronic HBV infection without E antigen seroconversion, the persistence of surface antigen longer than 6 months, accompanied with E antigen and the core antibody without E antibody, means the active carrier. The clinical significance of 6 common modes of HBV serological testing. Usually we first test the surface antigen. A negative surface antigen and the other markers show negative results, means no infection. A negative surface antigen accompanied with a positive surface antibody and positive E antibody, positive core antibody, means acute hepatitis B recovery period with immunity. A negative surface antigen accompanied with a positive surface antibody means recovery after vaccination or infection. A negative surface antigen together with E antibody and core antibody, there might be 5 possibilities. The first is acute infection recovery period and weakly infectious. The second is the purity of vaccination is relatively low. The third is the surface antigen variant or levels is lower than the detection range. The fourth possibility is the acute HBV infection window period or previous infection. The fifth is anti-core antibody false positive. If the surface antigen is positive, together with positive of E antigen, positive of E antibody, and positive of core antibody, means acute or chronic hepatitis B, highly infectious. A positive surface antigen accompanied with surface antibody positive, E antigen positive, and the E antibody positive, core antibody positive, means acute hepatitis B tends to recover or become chronic, weakly infectious. Next, we will discuss something about rare patterns and problems of hepatitis B serum test. The first rare patterns of HBV serum test is a surface antigen positive and HBV DNA negative. Is this contradictory? First, we should exclude whether there are technical factors that cause the HBV DNA to be amplified, such as whether the specimen handled properly, whether the viral nucleic acid is effectively extracted, whether there is the possibility of iodine leakage when iodine samples, and whether there are problems with the reaction tube. The second is the suspect surface antigen results. We should rule out various causes. The third is the virus resting period. The early HBV DNA method is not sensitive enough or inactive surface antigen carriers. Communication with clinicians. We should talk something about the clinicians to make sure whether the patient is in the antiviral treatment, the expression of protein and the replication of nucleic acid are not at the same level, and the half-life of protein is much longer than that of nucleic acid. The next rare pattern of HBV serum test is the surface antigen and anti-surface antibody appear at the same time. This might be the patient in the recovery period of HBV infection, and the immune complex of surface antigen and antibody existed in the patient. Also, this might because two HBV subtypes are infected, and one subtype has produced antibodies, the other has not yet. Also, there are mutations of HBV, which are common in newborn mother-to-child infection or patients with liver transplantation. Anti-surface antibodies seroconversion occurred in interferon alpha treatment, and the surface antigen could not be cleared due to S gene mutation. The third rare patterns of HBV serum test is E antigen and E antibody appear at the same time. The theoretical basis is the immune complex appears in the turnaround period. The probability of E antigen and E antibody appearing at the same time depends on the sensitivity of the detection method, the ability to detect immune complexes. When samples are tested, the antigen-antibody complexes in the blood sample also participate in the reaction and play a competitive effect. Therefore, when free E antigen and antigen-antibody complexes are present in the blood sample, it can be positive for both E antigen and E antibody. The level of core antibody detected by CLIA was higher than that detected by ELISA. CLIA has a higher sensitivity because it can coat more antigens or antibodies. The more baked, the greater the chance of hooking. The sensitivity of luminescence is much higher than that of enzyme immunoassay. When the content of the analyte is very low, enzyme immunoassay can no longer detect, but chemiluminescence method can detect. Why do ELISA kits recommended pre-dilution of samples for core antibody detection? The main reason is the presence of cross-reactive antibodies or interfering substances in the serum. The specimen has to be diluted for testing, resulting in reduced sensitivity. If the test is not diluted, there will be obvious interference, resulting in false positives. For the dilution test of core antibody, there is another argument. Original serum sample is used as an epidemiological survey result, and the test serum sample diluted to be tested is used as a clinical diagnosis basis. But this view lacks theoretical basis. Next, we'll discuss something about the impact of hepatitis B testing methods on the results. The history of immunology technology. The classical immunoassay techniques, including immunoprecipitation and immunoagglutination, in the late 1950s and the early 1960s, a complete quantitative measurement method, radioimmunoassay, appeared. In 1960s, on the basis of enzyme immunohistochemistry, scientists have developed an enzyme-linked immunosorbent assay. And since 1990s, it has become the CLIA era. The trends in laboratory testing of infectious disease. Currently, most laboratory testing of infectious disease are performing ELISA, colloidal gold method, or CLIA assay method for screening tests. But for confirmation tests, usually we use nucleic acid amplification testing or recombinant Western blot. The ELISA, enzyme-linked immunosorbent assay, use microplate solid phase carrier. It has the advantage such as simple and easy to operate, and also low cost. Also, it has some disadvantages. The first, the coating area is small and the reaction area is limited. So the sensitivity and the speed will be affected. Next, insufficient coating uniformity. This will affect the precision. Color response will affect the sensitivity and specificity. The fourth, inconsistent response time causes diversion of results. Variant strains are difficult to detect and manual operation difficult to manage. Only when the concentration is higher than 5 nanogram per milliliter, the coincidence rate is 100% between the ELISA and the CLIA methods. When the concentration was lower than 5 nanogram gram per milliliter, the detection ability of ELISA decreased. When some cases containing the mutation were tested, the ELISA had a limited ability to detect. Only 3 of the 3 variants cases were tested by ELISA. Next, we will talk something about the influence of hepatitis B mutation on test results. According to the heterology of nucleotide sequence of HBV genes, there are 8 genotypes and 9 serotypes. Different genotypes and serotypes of HBV pose a challenge for laboratory testing. Using chemiluminescence method can accurately detect different genotypes and serotypes. With the introduction of antivirus drug and vaccines, selective pressures has brought about more and more genetic mutations. In the study of 9 mutations, Mindray's chemiluminescence method was able to detect the infection status of mutated cases. For the prevention of hepatitis B, vaccines are effective measures. When surface antibody is less than 10 units, hepatitis B vaccine should be injected. In US, for children and adult hepatitis B vaccine schedules, including 2 plans. First is 016, 3-dose vaccine series, and the other is 2-dose vaccine series that is in the 0 months and 1 month after dose 1. Another preventive measure against hepatitis B is accurate screening of blood donors. The traditional surface antigen plus hepatitis B core antibody test can be more effectively to screen out of the all-cause HBV infection. With the implementation of HBV nucleic acid test, the value of maintaining anti-core antibody for the detection of low-level HBV DNA positive donors was confirmed. So above is the content which shares with everybody. Thank you. Thank you very much.
Thanks to Dr. Quinn. That was a great talk, a great presentation. So I am glad to tell you, everybody, that Dr. Quinn is going up to our line right now. So we'll see her later, I think, in the discussion session. So now the next speaker is Professor Dr. Ahmed Skapala. So he is a professor of clinical pathology, head of clinical chemistry and immunochemistry unit at the Faculty of Medicine, Zagreb University, Egypt. He has evaluated more than 40 research projects, and he has many publications, national and internationally, and also published more than 56 research papers since 1999. He is also the head of chemistry and immunoassay unit since 1999. Now, welcome, Professor Dr. Ahmed Kepler. His topic tonight is anti-Mullerian hormone assessment of ovarian function and beyond. Welcome, Dr. Kepler.
Welcome, Dr. Henry. Welcome, everyone. I am going to talk today about anti-Mullerian hormone. We all know anti-Mullerian hormone as a very important parameter and unique parameter in assessment of ovarian function. But when I tried to collect some data about this subject, I found that anti-Mullerian hormone as well is used in many aspects.
Open your video.
Share
Share the video.
Yes. It is shared already.
We cannot see you.
The video? Can you turn on your video?
Yes, it is on.
Okay.
Can you see me now?
Not yet.
Yes, we cannot still.
No. Maybe something problem with your camera.
No, it's fixed as it is. Okay, I'll try to fix it. Okay, meanwhile, I resume and I'll try to fix the camera. Okay with you?
Yeah, flashing.
Hey, no problem.
Okay. I don't know if it is ready, but I'll continue with the talk. Okay.
Please continue. It's okay.
Today we are going to discuss 4 points as regards AMH, which is physiology, clinical applications, variability factors, and laboratory challenges. Under these 4 main points, we will see that AMH is far beyond only ovarian assessment function. It is a very important point, but it has another aspects as well. So, as regards the physiology, AMH is a homodimeric glycoprotein hormone. Glycoprotein hormones, as we all know, they are stable, they don't fluctuate they don't have biological fluctuation. AMH belongs to transforming growth factor beta family, produced from granulosa and Sertoli cells, and the only type of cells which produce AMH. AMH physiology is responsible for the regulation of the Mullerian ducts in male fetuses. So you'll see here in this slide that undifferentiated fetus by the age of 8 weeks, when we start to produce AMH, causes differentiation, or let's say it causes inhibition of the Mullerian duct formation, and in the embryo leads to differentiation into females, which are not subjected to high level of AMH, and males, which are subjected to high levels. Here, as we see during embryonic and early childhood, that AMH in males are much higher than AMH in females. So it have a function in early life with male babies and fetuses. Among the clinical application, we all know that 1/6 of people, of couples in the world experience some form of infertility. And the first point as regards the fertility is the controlled ovarian stimulation, to induce ovarian stimulation, to introduce or to produce oocytes. Then it's collected in assisted techniques. But the point that we want to know the capacity of the ovary to produce this ova, and AMH is well known for all of us, is the most powerful factor as regards ovarian reserve capacity. However, in females, it have other different applications. As we said, is the gold standard for ovarian assessment. It helps to choose the stimulation protocol, prediction of poor or over response, hyperstimulation, what we call hyperstimulation of the ovaries. So AMH have a potential application above ovarian reserve assessment methods like ultrasonography or something like this. Also, in females, AMH not only serve as ovarian reserve assessment, but as a tumor marker, tumor inhibitor, assessment of ovarian damage due to medication or chemotherapy, prediction of menopausal age, prediction of pregnancy outcome, endometriosis, PCO or polycystic ovarian disease diagnosis, and autoimmune diseases. We will pass through these clinical applications fast. I choose to, let's say, demonstrate a case, which is 33 female, 1 year infertility with unremarkable history. When undergoing transvaginal ultrasound, we found 2.5 centimeter right ovarian mass. The routine laboratory test for ovulation, which is FSH and LH, were within normal values. However, as the mass is suspicious for malignancy, so they undergo CA 125, and it was quite normal within the normal reference, and AMH, which was high, 14.9, and the upper reference limit is 7.6. So after doing laparoscopic right salpingo-oophorectomy, histopathology, it was found it was a granulosa cell tumor. Post-operatively, repeated AMH fell to 0.6 nanogram per ml. So it is used in such a case as a tumor marker, despite having better sensitivity than CA125. So AMH is a tumor marker, as we discussed, for granulosa cell tumors. It's a tumor inhibitor, and we found in some cases anti-mullerian hormone receptor type 2, which could be used as a target for therapeutic agents to treat such a cases. So it gains not only serological importance, but also histopathological importance. When we start to treat patients with chemotherapy, the strong point that it will induce infertility. So we use AMH to predict ovarian function recovery. It's important to regain fertility for such a female undergoing chemotherapy. Even doing ovarian surgeries, like bilateral oophorectomy, we find that there is no level or undetectable level of AMH is reached after 4 days. Ovarian cystectomy patients have low preoperative AMH levels and should be managed carefully because it predicts the response after the surgery, even removal of small cells. As well as it can help in prediction of menopausal age, that low AMH predict early menopause and high AMH predict late menopause. It's used also in prediction of pregnancy outcome. AMH predict early pregnant loss, early pregnancy loss with low values. High AMH predict preterm birth, so it's important to measure it in pregnancy also. As we see, it's a wide spectrum of female or gynecological causes. With endometriosis, low AMH levels is found in endometriosis. We may serve as a therapeutic agent. Also, we can direct the treatment agent for AMH receptors. In autoimmune disease, in ovarian autoimmune disease and other systemic disease associated with gynecological problems, like we find low AMH levels in autoimmune disease such as rheumatoid arthritis, systemic lupus, Crohn's disease, and this is a very good protective marker for a subsequent development of autoimmune ovarian failure, which cause premature menopause. AMH is also very beneficial with diagnosis of polycystic ovarian disease. It is 2 to 4 folds higher in polycystic ovarian disease, and it might predict the phenotypes or differentiate between the different phenotypes. AMH is correlated with the severity and also with the ultrasonographic findings. As we see here, that AMH levels are much higher in polycystic ovarian disease than in the normal females. Again, it's not limited to only female patients, but it has some applications in pediatric patients. We will discuss again another case. It's 46XY newborn, have left retractile tests and right scrotal tests. So he has one only detected testis. At 1 month of age, right-sided inguinal hernia appeared. So the patient suspected to be inguinal hernia. Undergone serum FSH, LH, testosterone, and they were within normal reference range for age. At 3 months, this patient undergone herniotomy to treat the right-sided inguinal hernia we mentioned. And they found an ovary-looking organ. Subsequently, laparoscopic removal of uterus and fallopian tubes were performed in spite of having 46XY chromosomal pattern, which is the normal male pattern. Serum AMH was undetectable. AMH gene mutation was detected. And interestingly, 1.5 years later, the younger brother was born with a similar phenotype and AMH mutation, the same AMH mutation. So when we consider disorders of sex development, we will find that with 46 chromosomes XX pattern, which is the normal female pattern, we can differentiate some cases using AMH and testosterone. When we look for AMH and testosterone, if they fail within male range, then we have 46XX male. If they are above female range, we will have ovotesticular disorder of sex development. On the other side, if we find AMH normal in female range and testosterone above female range, we suspect extratesticular androgen source like congenital adrenal hyperplasia or placental aromatase deficiency. So as we see that AMH can, according to which, if it lies within the normal male or the normal female pattern together with testosterone, they can differentiate such a pattern in normal chromosomally normal female. For the 46XY disorder of sex differentiation, also AMH can be used to classify patients into 3 categories: if it is undetectable, if it is normal, if it is high. In undetectable patients, we can undergo testosterone. If it is also undetectable, this is testicular dysgenesis. And if we have normal testosterone, it's some sort of AMH mutation. When we find AMH to be normal, we have 3 conditions according to testosterone, either low, normal, or high. It will be low in androgen-sensitive defects. It will be normal in another type, which requires anti-Müllerian hormone receptor 2 mutation, and testosterone may be high with dihydrotestosterone sensitive defects. If you find AMH high and testosterone high, this is androgen insensitivity syndrome. So, as we see, AMH together with testosterone can differentiate a lot of disorders of sex development. Again, we depend on that the normal value for the female and male children are completely different. It's higher, just to remember, it's higher in infancy, and it goes lower in males, and the reverse occurs in females. However, it is not limited to disorders of sex differentiation or some of the gynecological conditions. It has also some application in males. Sorry, this request is in Arabic, but this is azoospermic male, and they require or ask it for serum AMH. Then he's azoospermic by semen analysis, no sperm could be found. Okay. For such a patient, when undergoing the routine laboratory test, FSH, LH, testosterone, they are within the normal range. However, AMH was high, and it can be used to differentiate between obstructive and non-obstructive azoospermia. In obstructive azoospermia, we find normal AMH with non-obstructive azoospermia or the obstructive or let's say the failure, testicular failure, we will have AMH level below the norm. So AMH can use to differentiate between undiagnosed cases of azoospermia, between obstructive with a normal value, non-obstructive with low AMH, in cases of delayed puberty in males. Normal AMH is associated with constitutional pubertal delay, and in case of hypogonadism, congenital hypogonadotrophic hypogonadism, we will find low AMH value. Also, male senescence, AMH levels reduce with aging. In spite there is a controversy here, it is already of low value. The third point is the variability, which might affect anti-Mullerian hormone measurements. A lot of factors contribute to the level of circulating anti-Mullerian hormone, like obesity, fasting, menstrual cycle, pregnancy, contraception. There are race or ethnicity factors. There is a circadian rhythm, in spite of not being that huge, seasonal variation, and is affected by vitamin D status and by smoking. However, they contributed a little to AMH level. The other important points that is related to the analytical variability of AMH assay is the assay specificity, sensitivity, precision, and assay uncertainty. It's affected also by sample type, transport, processing, and stability, like any other parameter we use to measure in the lab. However, specificity and sensitivity and the assay precision is of great importance, because with low values, we need a highly precise assay. What's the laboratory challenges we find in using or selecting a method for AMH? The first point is that we have to define and establish, like the CLIA guidelines, which say that age and sex assay-specific reference ranges, and as we showed before, that there is a wide variety of values between the age and the sex difference. So in each area, we must define our reference intervals. The second point is the standardization of AMH immunoassay. We need to have some sort of international standard, because international standard will help if we screen patients according to different methodologies to compare us. So the method comparability is a very important point. As for my knowledge, up to the moment, AMH does not have international standard, and my colleagues straighten me if I am wrong. Again, there is three players which use the luminescent immunoassay principle for the time being, and we will find that there is a difference between the low response and the high response, who consider this is a good ovarian capacity and this is a bad ovarian capacity, who consider it's good response for the ovarian stimulation protocol, and the other will find great difference between methods. So AMH is a promising biomarker for multiple clinical situations away from ovarian reserve assessment, provides clinical benefits that justify the additional effort and accurate interpretation. However, validation of age and sex method-related AMH reference intervals are mandatory. The establishment of the AMH international standard will serve to harmonize current and new assays. Thank you.
Thank you very much, Dr. Kepler. It was a great talk as well. So amazing with your laboratory observation and the case sharing. So thank you again very much. So next speaker is Dr. Raymond Simon Lopez. Dr. Lopez is an MD, Scientific Research and Medical Affairs of Mindray, IVD. So as I mentioned before, he is an expert in clinical and laboratory hematology, oncology, and immunology, and as well as coagulation and a lot of expertise. So he also worked for several international famous industries, previously before joining Mindray IVD. So he is a lecturer of artificial intelligence at the University of Applied Science of Southern Switzerland. Over 40 years of experience working in both laboratory and hematology industry. He has 8 patents accomplished and over 100 scientific papers published so far. So welcome, Dr. Lopez. His topics tonight is vitamin D and COVID-19. So welcome, Dr. Lopez. Dr. Lopez, can you turn on your
yes,
speaker?
Sorry.
Okay.
Sorry, it was closed, the microphone.
That's
yes.
fine. Okay.
Thank you for your nice introduction. And I have to say that I am very happy to work in medical affairs and scientific research for Mindray. I am very surprised and very happily that Mindray is doing a highly level of research, and it's really good to work in a company like that, collaborating with you guys. Okay, today I have to talk about vitamin D and COVID. From the first time I have seen the news about the involvement of vitamin D in COVID, I was really interested about that, because also in cancer, we have seen that vitamin D is important. And really, I was from the beginning following up this topic. This is the reason, even if it's not my specialty, hormones and clinical chemistry, I was happy to give this talk. Let's share my screen. Okay. As I said, it appears in 2020 and before in Sky News, for example, like important news that, for example, news like that, more than 80% of COVID patients are vitamin D deficient. Another coronavirus, vitamin D reduces infections and impact of COVID-19 studies find, and that was really amazing, because also appears in the news when everybody was trying to find solutions and treatments for COVID infection. But let's introduce a little. It's not me that have to do that, has to be a professor in clinical chemistry, but let's introduce a little the vitamin D. Vitamin D, as you all you know, is a fat-soluble vitamin. It's an steroid derivative, and it's an essential nutrient, an indicator of human health. It is mainly in the form of D2, vitamin D2 or vitamin D3. The vitamin D2 is converted from ergosterol in plants by ultraviolet irradiation to vitamin D3. That is producing because a photochemical reaction of 7-dehydroxycholesterol contained in human and animal skin cells after ultraviolet irradiation. For this reason, fat-soluble vitamins are vitamin D2, you can find it easily in plants, and vitamin D3 that only can be synthesized or in the skin with the sunlight, or you have to take oral supplementation. The source of vitamin D is the cold liver oil, the fish, such as salmon, sardines, cream, egg yolk, animal liver, milk, and sunbathing. How many vitamin D we need to input per day, and which type of vitamin D? Okay, for many of the, let me say, I have an affinity for the Mayo Clinic. I was honored also to work there in the Mayo Clinic for a while. And really, when everybody talks about ISO certification, the Mayo brothers, about more than 70 years ago, they defined something even better than the ISO certification. All the proceedings in the Mayo Clinic were listed, were written, and reviewed every 2 years by a group of experts during half an year, 1 hour per week. And for this reason, not only they have ISO from 70 years ago, but also continuous improvement, what in Japan methods, they say Kaizen, that it's always not only writing, but they do improving it every 2 years, a group of experts. For this reason, for me, it's like the gold standard and they say from the Mayo Clinic that persons commonly at risk for vitamin deficiency include those with inadequate sun exposure, limited oral intake, or impaired intestinal absorption. But clinicians may recommend supplementations, but they are unsure, the Mayo Clinic, how to choose the optimal dose and type of vitamin D, and how to use testing to monitor therapy. That represents that this point needs to be clarified, and we need to work on that. The vitamin D, as we know, have multiple functions in the bone health, in the neuromuscular function, in the cardiovascular effects. It's important for cell growth and regulation, for the brain health, and that is the reason we are talking today about COVID, immunomodulation. In the osteoporosis, that is a very, very important topic, because now many people in the world are elder and they have this common problem, the osteoporosis. And vitamin deficiency is very common across the world. We can discuss, and after we will see in one slide, there is no agreement which levels of vitamin D in that you can consider deficiency. But here we can see, considering the level of 30 nanomoles per liter in America, about 6% of the Americans have vitamin D deficiency. In Canada, 7.4%, and in Europe, 13%. Looks like in America, they are much more mentalized that they need to take vitamin D. But if you use the cutoff of less than 50 nanomoles, you can see 24% of the Americans have vitamin D deficiency. In Canada, 30%, and in Europe, 40%. That is a lot. And if we consider that now we are in the middle of the COVID infection, this can be a problem. Who is right? Okay, I think we need to investigate that much more, and to choose and to work with the two levels, to work with the level of 30 and measure and compare both groups from 30 to 50 and more than 50, in order to see if it's really clinically significantly differences if you have a vitamin D between 30 and 50, or the vitamin D is between 50 and 70. Something like that can be nice to do in a big groups of population with big data to see the clinical difference. And we need to work on that, honestly, I think, even if it's not my specialty. Reviewing what I have reviewed, I recommend that. Vitamin D and COVID infection. Now we are going to go to much more in deep to this topic. Does vitamin D have correlation with COVID infection? Looks like the answer is yes. Vitamin D insufficiency is associated with increased susceptibility to infections like acute respiratory tract infections. Vitamin D has been shown to decrease the risk of respiratory infections and or severity of respiratory infections. And here we can see an article that shows that from Martineau et al. Another article, vitamin D insufficiency is associated with increased susceptibility to infections like acute respiratory tract infections. Vitamin D supplementation modulates level of interleukins, and that is a very important topic. As we have seen in the COVID infection, one of the reasons for death is the cytokine storm. And looks like vitamin D has the power to avoid this cytokine storm. And that is a big, big issue. And you can give prednisone, dexamethasone, etc. Or looks like vitamin D is a very important topic. And of course, I prefer to give vitamin D than dexamethasone or other drugs. But the thing is, now we are going to see, we are going to begin to see in the next articles that it's not recommended to give a bolus like some people recommend for colon cancer in vitamin D in the congenital polyposis, but constant intake of vitamin D. For this reason, now not all the types of administration of vitamin D are the same, and not all the provitamins D's are useful for the treatment, as we will see afterwards. Vitamin D can reduce the production of pro-inflammatory cytokines like interleukin-6 and can reduce the cytokine storm that increase the mortality a lot. And that is very clear in this article from Xiaohao Shen and Binghong Zhao et al. In that article, we can see a little much more. I will not enter on that in deep. You can find in the literature. All these articles are you can download for free. They are in PDF format, but here it enters a little more in the immunomodulation in human infectious disease and the antiviral infection of vitamin D. And I recommend you to read this article from Xu Yi and David Bailing et al., published in a Journal of Translational Medicine. Again, in this article, the natural history of COVID and current knowledge on treatment and therapeutic options. It is known that vitamin D can stimulate the innate immunity and modulate acquired immunity. A meta-analysis that they did, reviewing many articles, show that evidence that vitamin D supplementation could protect against COVID infection. This benefit was observed in individuals who receive frequently doses of vitamin D, but not in those who receive bolus. And that is a very important evidence. How to treat, not with boluses. Even if you have a cytokine score, don't give a big bolus of vitamin D. It's much better to receive frequently vitamin D and not in a bolus. Again, in this study, that was a very important study. We can consider a big data from United Kingdom Biobank that the study was performed in 449 individuals recruited from the UK Biobank with confirmed COVID infections, in that they established that 25 hydroxyvitamin D concentration was associated with COVID risk. And but there is no potential link between vitamin D concentrations and COVID infection. Looks like you can have the same COVID, but not, but reduce the risk of severe clinical COVID. Again, they studied. I have not mentioned here, but they studied in this big data study that there is no. There are differences between ethnics. Between Afro-Caribbeans, between whites, but there is no any explanation of using vitamin D to explain this ethnical different risk of severe COVID in the human population. This was a study that Mindray, as I said, Mindray have an important department of research in that they have seen that among 167 cases of SARS-CoV infection, 135 cases had vitamin D deficiency and 23 cases of vitamin D insufficiency. As you can see, when we analyze the cases with COVID, with clinical COVID that needs to be in the hospital, the majority of them have vitamin D deficiency. And that is really an important confirmation of that. Again, in vitamin D deficiency patients with new corona needs more treatment than others. For this reason, you are going to receive much more dexamethasone, much more, respiratory support if you have a vitamin D deficiency. And last but not least, vitamin D deficient patients with new corona have longer hospital stays. For this reason, the majority of the cases with severe COVID have vitamin D deficiency. Second, they need more treatment and they need more hospital stays. I think it's quite clear that vitamin D plays a role in COVID. But some studies are critical a little, and they say that in this study, I like to also to look for the devil's advocate who says it's not so enthusiastical about vitamin D. Okay, we need to include also these articles. And this article from the French Academy of National Medicine, they say that vitamin D cannot be considered as a preventive or a curative treatment for COVID SARS infection. However, by mitigating the inflammatory storm and its consequences, it could be considered as an adjunct therapy to any form of therapy. But anyway, they recommend vitamin D to avoid the cytokine storm. For this reason, even the critical articles like that recommends vitamin D to avoid the cytokine storm. I have to remind that in other meetings about hematology, I have explained my experience in hematology, detecting and classifying the patients with high risk of severe COVID. I want to mention that I discovered that the patients that have high risk to enter in a severe or critical phase, they have high monocyte volume. The monocytes plays, but 2 days, 1 day before it occurs the cytokine storm. In that represents that we need to observe what we call in hematology cell population data, the morphology and the size of the monocytes, because the size of the monocytes can predict that will be a cytokine storm. And following this French recommendation will be indicated when the monocyte depth, that is the monocyte volume cell population data, will be the advice that we need to consider before it occurs to introduce vitamin D to avoid the severity of the cytokine storm. Another important part that I want to touch and to discuss during my talk is which type of vitamin D we have to do. We have to give. Many of the vitamin D availables, and the more famous are 25-hydroxycholesterol. We can see here in the next slide. But in this study, they mentioned that one type of provitamin D called calcifediol is the best available therapy versus other therapies to avoid the mortality of patients with COVID-19. For this reason, it's open. This was a randomized clinical study, with quite good design. For this reason, it's open which type of vitamin D we need to administrate. And in this article that looks good, it recommends calcifediol, that is a provitamin D, not the more common use in the therapy or supplementation for vitamin D. And entering in that, for example, not for COVID, for general people that have low vitamin D, this article says that cholecalciferol is the only form of vitamin D that should be considered in the context of nutritional functions. Yes, but looks like in COVID, they compare cholecalciferol, calcifediol, and calcitriol, 3 ways to administrate vitamin D, but looks like it's suggested that calcifediol will be the best one for COVID. Cholecalciferol maybe will be good to put your levels of vitamin D higher for osteoporosis, for other applications, but minimum we need to investigate, or minimum we need to consider or reconsider that calcifediol can be the first option in the cases of COVID-19. Just to enter a little, is not my specialty, but just to show you how vitamin D helps to fight against the virus. Here we can see that the macrophages that use B defensin and tachykinine to poke holes in the virus envelope that provokes also viral proteolysis that increase also the macrophage tropism and the vascular permeability, and with that processes, the vitamin D may help to eliminate the viruses. Again, here, vitamin D boosts humoral immunity and suppress cytokine storm. Is not my specialty, honestly, but here you have this slide, and you can make a photo if you want or copy the screen, but that is the way that is recommended to use vitamin D to avoid the cytokine storm, and this is the way that it works, okay? I don't want to enter in this slide. It's not honestly my specialty, okay? Good. vitamin D measurement looks like the best way to measure the vitamin D is the 25-hydroxy D, vitamin D, that have a long half-life, is stable in high concentration, and is the best way to measure vitamin D in blood. Now we are entering in the determination. Here, as I said before, it's not clear which levels of vitamin D we have to have. Here, the American Academy of Medicine have different levels than the Nutrition Science Advisory Committee that have lower levels of vitamin D, as they define the vitamin D insufficiency lower than the American Academy of Medicine. But of course, you have seen in America, many people are supplemented for vitamin D and how to calculate the reference values if many of the populations are supplemented is difficult to say, okay? But just to make in discussions that many countries use local guidelines to establish vitamin deficiency. The same that WHO has successfully, for example, in hematology, defined the WHO classification of hematological disorders, making a consensus between different countries of the world. I think a consensus is necessary between different parts of the world to define vitamin D deficiency. The Mindray test for vitamin D shows a very good quality control results with a very good coefficient of variation. Vitamin D has a very good precision from Mindray. The excellent precision and repeatability. The across platform bias, there is no bias. Comparing with other companies that looks like are also mentioned as a good reference for vitamin D, show a very good agreement of Mindray test with other companies. And finally, the takeaway messages for you, for all of you, is our vitamin D supplementation could protect against COVID infection. This benefit was observed in individuals who receive frequently doses of vitamin D, but not in those who receive bolus of vitamin D. Vitamin D in COVID assists the human immune system to eliminate the virus, produce antibodies, and reduce the inflammation storms. Calcifediol is suggested as the best way to administrate vitamin D for COVID-19 infection. And Mindray vitamin D determination have reliable performance, precision, inter-system consistency, and first-class anti-interference ability. This is a photo of a reactive lymphocyte from one of my patients with Epstein-Barr infection. And with that, I thank you very much for your attention. Thank you.
Thank you very much, Dr. Lopez. It was a great talk and presentation, and it's amazing that we have known tonight that vitamin D play a role in COVID-19. So by testing the vitamin D, so we will know the situation of patient who infected with the virus, right? Okay, thank you very much. And
you're welcome.
Yes, and the next speaker is Mr. Osama Said. Is a product specialist of Mindray who is in Egypt branch. So welcome, Mr. Osama. He's going to talk about Mindray CLIA solution to all of you. Okay, thank you very much. Welcome.
Thank you, Dr. Henry. Thank you, Dr. Simon, for your great presentation. It's an honor today for me to present Mindray for the CLIA solution and the Mindray chemiluminescence immunoassay system. Today we will talk about Mindray CLIA solution for immunoassay. As we can see, Mindray support all the customer from starting from small labs and the clinics to high-end customer and university hospital. As an example, CL900i is 180 tests per hour in benchtop, so it can fit the small labs and the clinics. And also we have the CL1200 with 180 tests per hour, bench top also, but different reagent position number, and the sample position is also different with the racking system. And starting from cell 2000I, 240 tests per hour, the standing floor, and with have the sample driving module with 300 sample position. Also, we can see the CL6000 with 400 tests per hour and floor standing, and the sample driving module with 300 sample position, and the buffering area can reach 290 sample position also. And we are waiting for the new innovation from Mindray for the new product for immunoassay, which will be produced in next few months. And all this product have using the same reagent bottles and substrate and wash buffer, so it will be very good for reagent management for the stock. And about the technology, we use the method for ALB-AMBBD glow method for chemoluminescence, as we use the magnetic particle as a solid phase coated with the antibody or antigen, and using alkaline phosphatase as a tracer, and dioxolone as a chemoluminescence signal generator. After that, the dioxolone produce very strong and stable signal, which we called as a glow system. And this method, compared with the flash system, the glow method have lower background and higher signal to noise ratio. And for our CL900i as a robust machine for primary lab, we called as one of the smallest fully automated chemoluminescence immunoassay, with the wide range is only 86 centimeters, with 15 reagent position and 15 position for sample by carousel. And also the first result appear after 17.5 minutes for specific tests like troponin or CKMB, which is very important for intensive care. Also, our package is only 50 tests and 100 tests, so it's good for the management for the small volume of testing. And our shelf life for reagent is mainly 18 months. And after opening the reagent, the onboard stability is up to 56 days. About Mindray reagent menu, we have the big portfolio for Mindray, including thyroid, infection disease, fertility panel, and we have the biggest tumor marker for this tumor marker test. And regarding the COVID-19, we have the vitamin D test and the antibody testing, SARS-CoV-2, IgG, and IgM, and also the neutralizing antibody, and waiting for the torch panel in this year. So we have the full package for the COVID-19 testing. Also, we have the BCT, procalcitonin. So talking about Mindray vitamin D as the main one in the COVID-19 panel, we have the performance, as Dr. Simon say, we have the basic performance as comparable with other company, and also we have the better within run precision, as we can see from this table. Within run precision for Mindray is only less than 6% compared to another company like Roche or another Siemens or something. And for the comparability, we use 208 samples to make this comparison with the Cobas E601, and we get this result for the comparison between Mindray and Roche for the vitamin D, and it's great intercept result to 0.096. And we know that when we reach to 0.96, it's a great comparison. And for Mindray vitamin D, we use the anti-interference material to not make any interference with biotin as example. So Mindray can detect the vitamin D level without any interference with biotin, and we can make this good result without any deviation until 30 nanogram per milli for biotin. Also about the stability for vitamin D kit for Mindray, we have the onboard stability up to 28 days. From this table, we see we use the serum and quality control material for low and high levels, and within the 28 days, the deviation is very low. So that means Mindray stability on board is very good, so it will be very good for the low samples consumption in the small labs. About the vitamin D reference range, as Dr. Simon mentioned, the cutoff or the deficiency or sufficiency is different among all the association, but for the highest standard now, the Endocrine Society or International Osteoporosis Foundation and the Canada Osteoporosis Committee, they're using the cutoff is like Mindray reference range, deficiency from less than 20 and sufficiency less than 30. And from Mindray, we detect that both of 25 hydroxy vitamin D2 and 25 hydroxy vitamin D3. So we can detect the both of vitamin D2 and vitamin D3. And about AMH, our studies suggest that the cut point of Mindray AMH for the prediction of ovarian response to be less than 0.69 gram per milli, which indicates low response to stimulation. And if greater than 2.24 nanogram per milli, it's indicate a high response to stimulation. And we can see this is a good comparison between Mindray and Roche company in the same study. And this is for the high result, and for low concentration also we have the same good comparability result. About the precision and the stability, we have this study also for precision. We make the mean of high value and the result was stable, and for the low value also the result was very stable for the precision, and the total imprecision result was from 2 to 3% only. And we mentioned the onboard stability before about the all Mindray agent is stable. So for AMH, our stability on board is up to 56 days. And now we will talk about the HBV virus. We have the 5 parameter for infection for hepatitis B. We use HBS antigen quantitative result and the anti-HBS antibody quantitative also result. And for hepatitis core antibody, we use IgG and the IgM combo. For HBE antigen qualitative test result and HBE qualitative result also, and we have the certificate for CE approval by List A certification for hepatitis B panel from Germany, for the CE mark by third-party TUV, which is mandatory to make this CE for the infection disease panel. And from Mindray, we use 5,000 samples and 20,000 tests to get this certificate for 2 years from German Red Cross organization. So Mindray infection disease panel, we are the first company has this certificate CE mark. And about the specificity for the infection disease, we have almost 99.5% specificity for HBS antigen and HBS antibody and HBE antigen, and 100% specific for anti-HBE. And about the analytical sensitivity, we can detect from 0.05 international unit per milli for HBS antigen and HBS antibody from 2 milli international unit per milli. And also we have the HBE antigen and HBE antibody, the same cutoff, all of them like Abbott as a standard for the infection disease. And we have the better result for sensitivity. We can detect from 0.6 pico international unit per milli for anti-HB core antibody. And our study and the performance for the infection disease panel, we have onboard stability more than 4 weeks, and the calibration stability is 28 days. About the mutation detection, we have the 9 kind of recombinant mutant, and the Mindray kits can detect the 9 types of the mutant, including the AY and the AD area, so we can detect all the recombinant mutant subtypes. As an example, if we can see and look for the detection sensitivity level here for the AD type of subtypes of hepatitis virus and the AY panel for the mutant, compared with Abbott, we have the same sensitivity of the detection level for this infection panel, and we can detect with the same sensitivity for the subtypes of the mutant form. And about the traceability, Mindray assures this traceability that the result the customer can use it as the same as Mindray standardized laboratory. As in Mindray, we have the standardized lab, thus the same reference method we use it as the laboratory to be confident for the report, for the result. As for example, this HBs antigen and HBs antibody have using the second generation for WHO international standard. So for Mindray, we have the traceability system for all the reagent products. And this is all my presentation for today. So I hope now all of you know more about Mindray products, and hope to have a great day for you, and please keep safe. Thank you.
Thank you very much, Mr. Osama. And it was a great talk and presentation as well. As a product specialist, your talk very clearly to me. So it's very great. So we have a person like you in Egypt. Thank you very much.
Thank you, Dr.
Yeah.
Henry.
And since the time limit, so we are going to end our webinar. So thank you very much to all for coming to this webinar. And you can put your questions on our club, lab club online. So we will answer one by one later on. So and also we can have a discussion there. So we would like to keep in touch. So thank you very much, and see you again next seminar. Okay.
Thank you very much.
Thank you.
My pleasure.
Thank you.
Okay. Bye bye.
Thank you, everybody.